Hello, everyone. Welcome. Welcome. Thank you so much for joining us today. My name is Karen Bell, and I'm an Associate Director for Partners for Advancing Health Equity, or the P4HE Collaborative for short. We are sponsored by the Robert Wood Johnson Foundation, and we are based at the Tulane University School of Public Health and Tropical Medicine. We are a national research learning collaborative that aims to bring together people and organizations that are working on health equity, including government, academia, community-based organizations, philanthropy, and the private sector. We convene these sectors to determine how to work together to attain health equity. One of the ways we do this is by providing spaces for activities to engage in insightful conversations on critical topics and promote actionable solutions. Today, we continue our two-part discussion titled Setting Health Equity Visions for Success. You can watch part one on our YouTube channel or on Facebook. We will hear from two health equity practitioners today who will share their experiences in addressing health equity from the perspectives of health providers and through innovative health data. Through sharing their successes and challenges in measuring and addressing health equity, or lack thereof, within health services, we hope that you can add what we learned from our panelists today with what we have learned during our last webinar. And we hope that you can combine what we've learned from all of our webinars to develop shared health equity definitions and goals across sectors, people, and organizations within our collaborative. As always, we aim to promote community empowerment and provide resources that will help in dismantling systems that impede health equity broadly. So before we begin our panel conversation today, we like to build on what we did during our last webinar by thinking together about our health equity visions of success. You know that your opinions and insights on health equity are very valuable and will help us drive today's conversation. So for this, we will be using Mentimeter to think together collaboratively. So to access the poll on Mentimeter, you can scan the QR code on your screen, or you can go to www.menti.com on your browser or mobile device and enter the code 3877-3165. So I'm going to do that with you all because we're collaborative, we do things together. So the first question should be coming up soon. It says, what does equitable healthcare look like to you? So you can answer this question in a few words, a sentence, a whole phrase, paragraph, whatever you want to do. You can have multiple responses. I'm going to put in my response as well to what does equitable healthcare look like to you? And your responses will show up as you put them in, or excuse me, as we put the responses in, the answers will show up. So go ahead and reflect on what does equitable healthcare look like to you? All right, we will see some of the responses showing up here. Okay, I see respect, access, equal access to healthcare by all segments of the population, better access in all areas. So yeah, definitely access is the issue or an issue. Access, equal access to healthcare treatment, services, and medication. That's very important as well. Without preconceived biases of providers, that's extremely important. Honesty and hope, I think that that's, or actually that was one of my responses, having some sort of solution for people when it's possible. Equal health outcomes regardless of race, age, location, et cetera, definitely. Availability across financial, technological, and geographical barriers. Yes, we definitely see that those are issues where we don't see equal access across financial, technological, and geographical barriers, and that is what we want. So we have to build those systems to maintain that for everyone. If you have more responses, you can add them, but if you want to continue to reflect on that, that's fine. I think we can pull up the next question if possible. The next question says, what are the barriers to equitable health care for all? What are the barriers to equitable health care for all? So I'm gonna go to the next slide on my phone so you can see it. And I'm gonna reflect on that response or that question, because that's sort of the point of our collaborative, is to not just talk about the problem, but develop solutions. And so think about, what are the barriers to equitable healthcare for all? And I think it's okay to spend some time reflecting on this, considering that, our vision of success, of health equity success, is seemingly far off. And so it will take time and effort to identify what we should do and what we can do. And so we want to take this time to outline what we should do by identifying those key barriers. So we have access, we have racism, socioeconomics, broken systems, broken policies, I think, is a great way to verbalize that. Lack of community, I think that's very critical as well. As we have said in previous webinars, that many of the solutions to our problems are in the communities that are most marginalized. So we need community to address these issues. Systemic issues like short-sightedness, yes, definitely. Bias in educational systems that aren't allowed to educate freely. The impacts of data and measuring data. Cultural blindness, that's an important term and concept. Thank you for sharing that. Yeah, systems of exploitation, I think that was mine. Systemic racism, definitely, and provider bias. Those are all things that we will get to. Access is probably the one that we see the most here, so we'll definitely discuss that with our panelists. As always, we really thank you and appreciate you for sharing and providing your input, but we're not just asking for your input just for fun, but we use that information to help this discussion that we're going to have. So because of your critical input and your critical thinking about this, we want you to please continue to share your thoughts and comments in the chat throughout today's discussion. And you can also join this conversation with your questions and comments beyond the webinar on Twitter by using the hashtag partners4HE. So like I just said, we're actually going to include some of your questions, comments, some of the things that we talked about or that you just talked about in this poll into the panel today. So let me first introduce our panelists before we get started. First, we have Dr. Michael Hasselberg, who is an associate professor of psychiatry, clinical nursing, and data science at the University of Rochester. Dr. Hasselberg is the first chief digital health officer at University of Rochester Medicine and is the co-director of the University of Rochester Health Lab, which is the health system's digital health incubator. He was named in the list of the top 50 in digital health in recognition of his work to improve health equity through technology innovation during the COVID-19 pandemic. Board certified as a psychiatric mental health nurse practitioner, Dr. Hasselberg completed his PhD degree in health practice research at the University of Rochester School of Nursing and a postdoctoral certificate in healthcare leadership at Cornell University. His expertise expands health and technology as a Robert Wood Johnson Foundation Clinical Scholar Fellow and advisor on digital health modalities to the New York State Department of Health, the Department of Health and Human Services, and the National Quality Forum. He also serves as an independent consultant to several digital health startup companies, private foundations, and health systems across the country. Michael, thank you for joining us. Next, we have Christy Valentine Fiard. Dr. Valentine is the president and CEO of Healthy Blue, and she is a New Orleans native. She received her bachelor's degree from Xavier University of Louisiana, her medical degree from the Louisiana State University School of Medicine in New Orleans, and completed her residency at Tulane University, specializing in pediatrics and internal medicine. Dr. Valentine received a merit scholarship and completed her MBA from the University of Chicago Booth School of Business. She holds numerous positions and appointments, including serving as a New Orleans East Hospital Board Commissioner and serving on the Louisiana State Board of Medical Examiners. Dr. Valentine previously served as Louisiana State Medical Director for Reproductive Health and medical consultant for the Louisiana Bureau of Community Preparedness, and was vice president of the Louisiana Medical Association from 2017 to 2019. Dr. Valentine is the immediate past president of the New Orleans Medical Association. She recently was reappointed to the Federation of State Medical Boards Ethics and Professionalism Committee. Thank you for joining us, Dr. Valentine. Okay, thank you both. Thank you. As you can see in the chat, all of this information is in the chat. You can click the links for more information about our panelists, but I would like to start by asking you both. We specifically asked you all because you are healthcare, health equity professionals and experts. So we want to make sure that we are understanding what you are doing. Like how would you describe your health equity work? So we'll start with you, Dr. Valentine, and I see Dr. Hasselberg that I need to unmute you. So while Dr. Valentine is going, we'll work on that. Go ahead, Dr. Valentine.
Yes, so thank you. Thank you for inviting me, and very excited to participate, especially seeing all of the communications and the participation leading up to this. But Healthy Blue, our health equity work is quite expansive. You know, it's an opportunity that I'm grateful to have here at Healthy Blue, where when we identify inequities in health, then we move forward with looking for solutions, just as you mentioned, solutioning to those problems that we see across our state, and taking the opportunity to learn from Elevance, things that may have worked in other states, in other markets, and bringing all of that goodness here to Louisiana.
Dr. Hasselberg, we're working on your phone unmuting. Do you have it?
Can you hear me now?
Yes.
Oh, perfect. Well, thank you so much for having me. My work in the health equity space, started really early in my career. I started off as a psychiatric nurse practitioner in rural New York State, where I was the only psychiatric provider for 6 counties. So I served the jails, I served the nursing homes, I served the outpatient psychopharm clinic, and I became really passionate about rural health and the disparities that faced individuals in those communities in regards to seeing specialists like myself. And after that experience, I've kind of based my entire career at the University of Rochester of trying to figure out how do we get specialists and healthcare providers who are typically located in urban, suburban settings out to these rural communities leveraging technology.
Would you be able to share a bit more about the role of technology in access to healthcare and really health equity? What do you think are those issues, and what do you think are some of the things that we need to be working on first?
Sure, yeah, so I'll give you an example. Yeah, I think we all experienced March of 2020, the world changing, and with the COVID pandemic and everything shutting down, and we were all kind of forced to video conferencing platforms for everything we did. The same thing happens with our patients. We did not want them coming into our hospitals. We did not want them coming into our clinics. And telemedicine, which has been around since the 1950s, really became a thing. And we started deploying it. Our work at the University of Rochester found that in our rural communities, which the majority of those communities are high poverty, they're either uninsured or underinsured, and Medicaid patients did really, really well, using telehealth technologies. And, not only did they engage in care more often than we were seeing in person, their outcomes, were actually no different, and in some cases better than in person. These patients didn't end up in the emergency department more often than those coming in person, and actually required less high cost labs and imaging tests. But there was a caveat in our data. It was in these rural communities that patients were only engaging in audio only, not video telehealth. And the first thing that jumps into folks' mind is broadband access. There's no broadband access out in these rural communities. So that actually was not the case in Western upstate New York. We actually have a really significant investment in broadband infrastructure across our state. It was the patients in these rural communities could not afford internet in their home, and the only internet access that they had was their data plans on their cell phones. And when you do video, it's a very data intensive technology feed, and folks didn't want to use up their data plans for video. And so now we're spending a lot of time and energy to think about, how do we leverage cell phones and not eat up data plans to deliver healthcare? And I can talk about some of the things we're doing in that space, but also how can we identify new access points to healthcare in these communities that are non-traditional, places like churches and barbershops and libraries where folks are already going that have internet available in them, where we can deliver healthcare into those locations.
Yeah, I appreciate you sharing that for a lot of reasons. You demonstrated how sort of the statistics and the results were different from what we would hypothesize, that people actually did better with the telehealth. And then you also described the actual real experiences that people had, that they had to call in because the video was not something that they could do with that with access based on their cell phone coverage or cell phone plans. I wanted to ask you, Dr. Valentine, if Dr. Hasselberg's sort of determinant that he focuses on is technology in healthcare equity, what are some of the determinants that matter to you when you're doing the work in access to healthcare or just healthcare equity? What are some of those things that you're focusing on?
Well, no, I think one of the things that was mentioned that is critically important is making sure that you are communicating with people in a manner that they may prefer. And so that's another thing that I heard mentioned, was just really finding a way that you can meet people where they are. And instead of telling them what's best for them, asking them what they see for themselves in their healthcare. I mean, at Healthy Blue, we do, I believe, a very good job of identifying where there may be those opportunities that we see where it wasn't necessarily a broadband issue. It may be where we see people not going to appointments because they have transportation problems, they have housing insecurities, food insecurities, those really top of mind drivers for an individual. If you have to choose between going to your doctor and making sure your family has food, then that decision becomes very easy. And so what we really work hard at Elevance and Healthy Blue to do is making sure that we keep that healthcare at the top of mind so that individuals don't necessarily have to do so, that we also address those social drivers that may be out there. And when you think about health equity overall and helping people have that fair and just opportunity to live as healthy as possible, it really brings to mind to me where we have some challenges is you're actually first of all, you have to actively search for it, because a lot of times it's a blind spot. People don't know that the way that they may be behaving is actually causing a disparity in outcomes. And that's something that I think, the more that I work with the team and the way that we just proactively look at the members and communities we have the honor of serving, and seeing where there may be more opportunity, even things that may not have fallen on our radar, but things that we possibly even learned from other areas in the country. Something that comes to mind is just even thinking about inequities that may occur with one particular provider, the members that provider serve their patients, that there have actually been inequities found between the members in a provider's panel, where majority patients have better outcomes than minority patients. And so how do you have that conversation with a provider? And how do you do so in a way where you're really wanting to connect with that individual and solution for what they know would be, best for their patients? People go into this because they want to be of service. And so if you then provide evidence that there may be inequities in outcomes, that can be a mirror that's difficult to stand up in front of individuals. So, but I think that it's important that we do that and find ways to communicate with people so that they are treating their patients in equitable manners. So then their patients can have equitable outcomes, and we don't see the disparities that we all know and have witnessed.
Thank you for putting it that way, because I was literally having this conversation with my class last week about implicit bias training and how we focus on this concept of cultural competency. And one of the things that you just pointed out and was pointed out in our last webinar, so I'm plugging that, everybody should go watch it if you didn't watch it live, is there online, is this concept of like people like you and Dr. Hasselberg, who may or may not have experience in different sectors, but how to communicate across sectors. So how do you communicate with that physician who, might be very well-meaning, might be an excellent provider in terms of overall outcomes, but we're seeing those inequities within the treatment from one provider? What do you do? How do people communicate across quote unquote cultures? Here we're talking about a doctor versus a someone like you who is in charge of the healthcare sort of systems level. What are some of those things? I think Dr. Hasselberg, you can also potentially speak to that, because I would imagine that there are sort of communication issues, or like people are speaking different languages if you're talking about people who are in rural communities compared to and thinking about how people in urban communities or people who don't live there might understand those experiences. So I think this is really to both of you all. How do you all deal with communicating those issues, those concerns to people who might not understand and might, be well-meaning, but they just don't get it because they don't know?
A lot of education on our provider side and our clinician side, just getting to collect the data around social determinants of health and potential health equities was just a challenge in and itself on our clinician side of, telling them and helping them understand the importance of why would we want to ask about food insecurities, and why would we want to ask about financial insecurities. And it actually, some of our clinicians became anxious about even asking those questions because, they say, well, I prescribe a pill for this and it takes care of this, but I can't prescribe a pill to take care of food insecurities or financial insecurities. So I don't want to ask the question. And so, it was a lot of change management and around, well, if you don't address someone's financial insecurities or food insecurities, not going to be able to afford that medication you prescribe for diabetes, and vice versa, and they just continue to have bad outcomes. So we've done a significant effort. We started with the data and asking the questions, and why that's important, and then as we kind of move from, okay, we've got the clinicians feeling comfortable to ask the questions, then providing the education around resources and how the resources may be different in the urban communities that we serve to the suburban to the rural communities. So we don't have it perfect yet by any means, but it is a significant effort, at least at my health system, that we're working on.
Yeah, and I absolutely agree with Dr. Hasselberg. I mean, I think that it is important to remain flexible in having those conversations. And, one approach, because, I absolutely recognize that there will be many approaches to this, but one approach may be, just as mentioned, starting with data and where just objectively what the information is revealing. And then staying open to allowing the individual that's a provider, who is a person, take that in a way that is collaborative, not accusatory, and maybe there could even be systems set up in the practice beyond that provider that may also lead to those disparities. Because as you mentioned, someone taking care of patients, they're thinking about those things that they could solve and fix right then. And they can't solve and fix everything, but they also have support in the office that may give training to certain individuals and may not train others as much. They may have certain cues or diagnoses, or just, it could be that the support around that provider may need to be tweaked as well. And bringing that to the provider's consciousness and in front of mind may help them better receive it. I think in all of this, it's important to really present the information in a way that it is received, and that then you don't necessarily alienate a provider that we really need at the table to make sure the people and the individuals in our communities stay as healthy as possible.
I really like that concept of building the support, really, for the provider to be able to do equitable healthcare or equitable treatment, whatever the proper term is, but also thinking about this sort of continuum, like a praxis, kind of to get to this goal of equity, like you were talking about, Dr. Hasselberg, where you start off with education and then you go to the next steps and then the next steps after that. One of the things that I'm hearing, and I was thinking about how to frame this question because I actually have several questions, but the one that I want to ask right now is about listening to patients and listening to, for example, Dr. Hasselberg, the rural patient or patient group that you're dealing with. Dr. Valentine, on your end, the patient who needs transportation help or who can't make it because they have to take care of their family, just like you said. One of the things that we have talked about, again, in previous webinars, go listen, is this concept of storytelling and how that kind of data can be used. So I'm wondering about how do you listen? What are the ways in which people who are in charge, like you all, can listen to the people who are in need, the people who are affected? Do you all have experiences with that?
So a couple of ways, at my health system, we have over a dozen patient advisory councils, and these are councils of our patients who represent different groups. So this could be a minority group, this could be rural group, this could be an older adult group, and we leverage our advisory councils around a lot of the things that we're planning on or hoping to roll out in our health system. We want to hear those voices of around how do we design it to meet the community needs. What is the right timeline of rolling this out, and then get feedback from those advisory councils once we start deploying it, so we can iterate and make sure that it's doing what we intended or hoped it would do. The other thing that we've made a conscious effort at my health system is trying to understand all of our patients through their own voice. And when I mean about that is, when I go to, let's say, your electronic health record, Christy, I can see when you came in for visits. I know maybe what medications you were on or what past diagnoses you may have and what labs and imaging are in there, but I don't really know who you are. And so, we made an effort at Rochester about 8 years ago that we wanted to collect patient-reported outcome data on our patients. And, we're the home of the biopsychosocial model at Rochester, which is this concept that a patient's physical elements is, you can't address that unless you understand someone's, social functioning and their psychological functioning or their emotional health. And so every single patient that came into our health system, and still to this day, we collect your emotional distress levels, your physical functioning levels, your pain interference, and your social functioning on every patient. And so we're hearing from the patient's voice how they perceive their health to be given their situation, and not per se what their hemoglobin A1C score says. And that's been really, really impactful for us. And then to take it a step further, we geocode every single patient that hits our health system, right down to their address level. And then on top of those geocodes, we can overlay these patient-reported outcome data. We can overlay the social vulnerability index or the area deprivation index. And then we're really starting to understand, patients in different parts of the communities we serve, what their profiles look like, so we can make sure we get the right resources out to them.
And perfect segue, because what we do at Healthy Blue is encourage all of those behaviors so that our members get the quality of care that they deserve. And so what we do, the data that you mentioned, as far as collecting that beyond the individual with their physical health diagnoses, but making sure that they do have that behavioral health care as well. That's the other part that I would add to everything that you mentioned, because at Healthy Blue, we have an integrative collaborative care model that does just that. It's something that was homegrown here at Healthy Blue, Louisiana, and recognized nationally, frankly, as innovative. And it's a way that we work with providers and encourage that collaborative integrated care, so that when one of their patients go into their office, they are collecting that additional information, those Z codes, if you will. So if they do have any homelessness on whatever outside of the physical may be impacting their health outcomes, work that I'm honored to be a part of, and something that our team is extremely passionate about. So that outreach that we do for our members and finding out, did they make that appointment? We have case managers, community health workers, practice consultants, that literally connect with our members to find out, how was that visit? Do we have to meet them at the visit and make sure that they have things that they their questions are answered, or if they have any additional questions even after? That's something that happens all the time. You're at the doctor's office You can think of all kind of things you want to ask before you go there, and then everything after. And while you're in that moment, you may not get those questions asked or answered, and bridging that and having a team that I'm extremely grateful for, that leans in to make sure that we are asking those questions, getting those answers, helping our members truly lead the lives they were designed to lead, and be as healthy as possible doing so. So it is, we may have a lot of information at our hands, but ultimately the true source is the patient, and finding out what, because what we may think is of top priority, they may have other things that are much higher on their list. And so how do we bring those together? How do we actually help them address the issues that are guiding their life decisions, and supporting those life decisions in a way that does lead to healthy outcomes?
Yeah, someone in the chat, Dr. Watts actually summarized these sentiments very well, that we have to look at patients as whole people, and sort of using whole people care. That's different from, like you were saying, Dr. Hasselberg, their A1C number. People are not their A1C number, they're a whole people, and they have whole lives, not just that number, and not just that doctor's visit, like you were talking about, Dr. Valentine, where we have other things that we're dealing with. And so I think that that's important. And I think that that is something that I personally will be taking with me from this chat. I did want to ask an additional question that's sort of different from what was just said, but it's actually based on what you all just said. You all just talked about how you all develop specific models from each of your institutions or each of your organizations. And so I was wondering about like distinctive things about the places in which you work. For example, Dr. Valentine, you're here in New Orleans. I'm not from here, but this is a very special place that has wonderful things, but also some very specific issues that shape, what we see. And I'm sure Rochester is the same way. I've never been to Rochester, but I would imagine that, the context of upstate New York and a city like Rochester that has a specific history impacts what you all are doing. So I'm wondering if there are like place specific things that shape your work, and even, I'll take it a bit further, shape your vision of health equity in the work that you do. Are there things specific to the place in which you are that shape your work and the specific health equity vision that you have?
I'll go. We're both going off mute at the same time. Go ahead.
You go ahead. No, you go first.
Okay, well, you're right. Louisiana is a very special place. I think that it's important here, being a homegrown Louisianian, New Orleanian, that you respect the culture that individuals and communities celebrate. So right now we're in festival time. And so, and our weather is beautiful for it. So you have to respect that. People are going to want to celebrate with food. They're going to want to celebrate and really maybe splurge on what the designed or preferred practice may be by their provider. But I think that it's important to in really connecting with someone is respecting the culture that really means so much to all of us. In being collaborative, I think that it's important not to go in and say, you have to do A, B, C, D, or that, and that's it. And there's only one way to structure it. That flexibility and then agility in executing on a plan for that specific individual is very important.
I love that, Christy. Rochester, we do have a very proud history, both a good history, but also, a bad history in some ways. And don't come up to visit Rochester in the wintertime. It's not a nice, it's not like Louisiana for sure. But, there's a lot of diversity in Rochester. So, we have everything from the inner city, which looks like any mid-size inner city, but you go 20 miles outside of the city limits, and it's farmland. So again, significant diversity, but it's a close knit community, and that is something I think we've always been proud of. So when it comes to healthcare in particular, there's really only two healthcare providers in town. There's the academic medical center and then the non-academic health system. And, we actually work together. We don't actually identify each other as competitors, but we come together, and we really only have one insurer in our market. And so when it comes to doing larger kind of transformative healthcare things, we typically all come together to do that. We're also a history that is innovation is just kind of part of who we are and what we do. So, some of the most transformative companies in the world, like, Eastman Kodak Company, where, everything digital, was, driven by, Kodak, and Xerox and computing, all came out of the Rochester area. And yes, both of those companies have, it's bright points, but also, things that they've done to the community that were concerning in the past. But, fast forward to today, no longer is the largest employer in our community a tech company. It's the University of Rochester. And so, we kind of take on that of, we are here to support the entire community as the largest employer, but we're also have that innovative ethos of trying to think outside of the box to meet the diverse needs of our entire community. So that's one of the things that I love about Rochester, is just that it has that homey feel to it. It is very tight knit despite all of the diversity within a small geographic area.
Thank you. Well, thank you for sharing about Rochester. I learned a lot, but also sharing about this concept of a history of innovation. And Dr. Valentine, thank you for sharing that as a native about how you have to respect the culture. And I think that goes hand in hand with respecting people, right? Because culture is part of people's lived experiences and can be a part of their identity. So I really appreciate you sharing that. I think we would want to sort of bring this conversation to a close, sadly. But if you had any closing thoughts about what you're looking forward to with regard to doing your work, like what is driving you? What are you really like, yes, I'm very excited about this and we're going to see this from this work? What are you thinking, and how can we sort of share in that excitement?
So what I'm extremely excited about is the fact that I am blessed to work for a company like Elevance Health that says we are here to identify inequities wherever they exist. And that is something that is passionately communicated. It is built into our culture. It is built into how we are even the decisions that we make, the programs that we set up, and having a moment that I believe is coming, where when we double click on different disease processes, when we double click on different communities, that we won't see inequities in care and in outcomes. I know that having the P for HE and these spaces where you allow the interface from different aspects of the community to all come together and form this collaborative think tank, that will help us move to just that, a day where we will talk about how there were inequities that existed and no longer do. And I'm excited for that day. And I believe in the power of words and then leading to actions. And so it's that's what drives me and really what motivates me at work every day.
I'm excited that we're having this conversation. When I started in healthcare, 20 plus years ago, these weren't conversations that we were having. So I'm really excited that, now, folks are talking about health inequities. I'm really optimistic about where healthcare is going in this country. And I say that because, we learned a few things from the COVID pandemic. One, that there are opportunities with technology. Two, we learned that healthcare, as usual, is not sustainable. Like, we need to start moving towards value-based care and moving from, the KPIs of how many surgical procedures can I do in an hour and how many patients can I see through my emergency department, to how many days can I keep someone healthy living in their own home. And I think you're seeing a lot of investment now in healthcare from new market entrants like retailers and big tech moving in, looking at, trying to bring care outside of those hospital walls. And that actually excites me, because that's going to force health systems like mine to start thinking differently themselves and realizing that we really need to be focused on keeping people healthy outside the wall, everyone healthy, and not focused on, bringing people into our hospital walls. So I'm excited for where we're heading.
I want to say thank you to you both. I actually was looking at my list of questions and I did not ask almost all of them, but I'm so inspired by what you all have said. And I think that as we continue to do these series, healthcare access and the experiences that people have in the healthcare system are so critical to this concept of health equity, but also thinking about it as just a part of a larger health equity sort of force that we're all trying to go toward this. So I really appreciate you all. Thank you so much for spending this time with us.
Thank you. Really appreciate the invite, and it was a great conversation. So thank you.
Thank you.
Yeah, agreed. This was a pleasure. Thanks for having me.
Of course. Thank you so much. I actually want to bring us all back to this sentiment of what excites you. What are you thinking of in terms of next steps? I want to pose to the audience, what are you taking with you today to advance health equity in your work or in your life? So you can go back to Mentimeter and you can just type in what you are thinking. What are you taking with you from today's conversation to advance health equity in your work or in your life? So that's not necessarily just, what you do when you're getting paid, but potentially what you do in your community work, what you do in your personal life, how you're working with other people. What are you taking with you today to advance health equity in your work or in your life? So what are you taking with you today to advance health equity in your work or in your life? Optimism, love that one. Yes, I think that when we are doing this type of work, thinking about systems and how we create health inequities, we can often lose optimism, but we have to have a practice of hope. So I thank you for that. Collaborative, integrative health concepts, thank you. Someone put in the chat, health equity is portable. I really like that. Collaborations that share values of equity and community-centered action, definitely working with like-minded people. And then understanding this concept of a whole person. Yes, that definitely rang true with me as someone who uses healthcare and someone who's involved in the public health system. Emphasizing the critical importance of including a shared collaborative perspective in advancing this work. Awesome. Thank you so much. Collaboration is what we do here at P4HE. So that's really the point. So I appreciate you all for your responses, for participating. But really, the point of participating is for you to reflect as individuals and as people who are interested in advancing this concept, this goal of health equity for all people. So with that, we want to thank you all for joining us today. For those of you who have registered for our workshop on health equity measurement tomorrow, we look forward to hosting you and spending that time with you on this critical subject. We would like to invite everyone to join us on Tuesday, May 16th for our next webinar titled Balancing Business and Health Equity Private Sector Efforts. This webinar will bring together voices from the private sector to speak about their organization's health equity vision and goals and discuss balancing social responsibility and profitability with community investment. Please follow the link being shared in the chat or by scanning the QR code in your screen to register and learn more about this upcoming event. More information about all of our upcoming activities are on our website. You can also sign up to be a member, to learn more, to get our newsletters, emails. Again, you can go to that website. You can also follow us on social media. As you can see on the screen, we are on all the platforms. So just go ahead and click that follow and that like button. You can also on social media help us spread the word by sharing our content that most interests you and your work. See you all next time.